In the past, we've talked about pterygia. Here's another recording, and now you see a different camera as a comparison. This is a GoPro modified to work on a microscope. And pterygium removal in this particular case is a smaller one. Oftentimes I incise the conjunctiva first after marking. It's already numbed with lidocaine with epinephrine, and then I separate the conjunctiva from tenons, tenons being the true culprit, at least the part that we want to remove most of.
So you're actually separating out conjunctiva from tenons, but trying to then go inside to get tenons, or you're going to end up taking conjunctiva as well?
Only a little bit of conjunctiva, the head that's pulled over onto the cornea. And as you can see now, I separate tenons from conjunctiva and try to go as far as I can, but not touching conjunctiva, but just separating those two layers.
I see. Got it. So this is the dissection out, trying to separate that tissue as much as possible to get ready to remove the rest of the pterygium here.
And some of the spots that you may see are just little droplets that at some point were unfortunately placed on the lens. Later videos, they'll go away. The dissection part that takes the longest. I want to make sure that I remove all the roots. That's how you can think of the tenons. And as you can also tell, that kind of pulls everything over. As soon as I just do that removal, conjunctiva relaxes and moves over, even though I've not cut off any conjunctiva yet.
Now, why is there this manipulation of that leading edge of the actual pterygium there?
So the pterygium grows, but then the cornea is flat, so it wants to kind of adjust to the elevation of the pterygium. So that's oftentimes a buildup of scar, almost like a Salzmann's nodule, extra scar tissue in front of the pterygium. Then if I don't do that, is not removed, and I've seen some patients where the pterygium was removed, but that scar was left, so they still have a lot of astigmatism. So that allows me to smooth out the cornea and remove any kind of traces of what the pterygium caused as far as distortion.
So definitely don't want to leave that mound there at the leading edge. That was removed. Now we're seeing, whoa, that came off pretty quick right there. Seeing the actual dissection away off the cornea. Sometimes we look at this and we say, well, they're going to have scar tissue beneath there.
Always.
Is there anything to do about that? Is it just going to be there forever?
Usually, yes. Only with a microscope visible, not as visible from afar. And there are certain things that can be done, maybe to decrease the scarring. Some people use mitomycin C on the cornea. I've not found it particularly helpful, and for me, the risk of using a chemical that can interfere with healing at least doesn't quite outweigh the benefit, or at least I should say the benefit does not outweigh the risk. So I usually tend to keep things very limited, also with how much cautery I do to stop the blood. I just need enough so that it doesn't bleed all the time, and you can see it. There's barely a few spots of cautery used there.
So definitely trying to catch these pterygium and remove them before they cross over the visual axis, knowing that it's going to leave that scar tissue behind. That's going to be ideal here.
And reasons for pterygium removal is also fair is appearance. If a patient doesn't like how it looks, if they're irritated, meaning it always feels like there's something in there, they're frequently red, or it starts affecting vision. And besides covering, pterygium can also cause a lot of distortion called astigmatism, and removing the pterygium oftentimes improves the refraction, or at least helps glasses work again.
I'm glad you mentioned the part about tenons, because right now you're grasping onto tenons, and that part with the ink on the surface is conjunctiva, so that's still being dissected away from each other.
Right, and as you can see, again, the conjunctiva drops back, and you can see how there's much less tension on it now as before, as I remove the kind of scarring that's underneath. Pterygia can also affect contact lens wear. If you imagine there's an elevation that the contact lens rests on, it's not very comfortable to have that.
We saw it really quick, but you were using your calipers, I think, to measure the size of the wound, and now we're going on healthy conjunctiva of the superior conjunctiva to find where we're going to graft that tissue from.
Correct. And the superior conjunctiva, because it's not exposed to sun, the theory behind pterygia is mostly sun, wind, and dust, oftentimes, the weather in Arizona. So that, unfortunately, causes recurrence, and if it's protected by the lid, it also tends to heal. Now here, again, I want to split tenons from conjunctiva and only remove conjunctiva because it will then heal back over, and usually after a few months, it's healed well enough that you could technically, and I've done this in the past, use the same site to get more tissue if you had to do it again or cover another defect.
That's tricky. It's like your own harvesting farm right there of conjunctiva because it's going to heal.
Yes.
How long does that take to actually heal back once you've removed this tissue?
Usually 1 week, patient is comfortable, and here you can see I try to be very careful with the conjunctiva using forceps that have little rings on the end so they don't tear. This is very fine tissue. You can see how you can see through very easily as the scissors are underneath it. And this is done under topical anesthesia. I only use some injections around the eye, but you can see the eye can still move, patients can still see, but they're comfortable enough with this kind of numbing that the recovery is very quick and there's very minimal trauma from this kind of procedure.
And when you say topical anesthesia, truly just eye drops for numbing in this case, no injection of numbing?
The injection is carried underneath, as you saw initially with the syringe, so that it both separates the tissue but also provides additional anesthesia, but it's done just underneath the conjunctiva, underneath the area that I work under. Here I spread out that tissue to make sure it's oriented correctly, and then glue is used, 2-component glue separated, that then adhere the tissue so I don't need to use any sutures.
And you're keeping the positioning apical and base side of the conjunctiva consistent, so glue is applied to the back, or?
The back, exactly. So that way the conjunctiva can adhere. And this is the other reason why I don't like to use a lot of cautery, because I want the blood vessels there to be able to supply the graft so that it sticks, heals, and provides the patient with adequate support in the long run, and there's no scarring, or less scarring afterwards, I should say.
Glue is usually sufficient, or stitches are sometimes used as well?
Stitches are definitely sometimes used as well. Most commonly, initially I used sutures and glue, but I found that the sutures are irritating because as they heal, or as they dissolve, more inflammation is caused. And just the glue itself, when it's used how I do it at least, low tension tends to stay in place just as well. What I remove there, what I pull is residual glue, is almost like a little bit of snot. The glue is fibrin and fibrinogen, so same thing that causes blood to form a clot into components, so that way it's nice and clear. And here I just close the gap around it to make sure that the conjunctiva attaches again, and there's very little bare sclera, ideally no bare sclera at all.
And that's what we're seeing now, is just the final portion, just removing that little bit of extra tissue there and opposing those two original conjunctiva and new conjunctiva closely together.
Yes, and again, you said tissue is more the glue you saw. Even if you drop, you need minimal amount of glue, and the kind of glue that's left over leaves that almost not transparent because as it's removed, so it doesn't stick and the patient's not tempted to wipe away, because that can dislodge the graft. That would be the one risk.
Nice.